How's everybody doing this morning? Well.
Good. Everyone's good. How are you doing?
Well, thank you.
I'm good, thank you. Let's see if I can. Can you guys see the presentation?
Yes.
Yes.
Thank you very much. Let's give it another second or two. I think we're all here, actually. So, awesome. Okay. So maybe we should just get going then. All right. Okay. So let's get going. Whoops. Okay. So this is a 15-year-old who has a history of depression, and this tracing was sent to me by Ellis Rochelson, who is a cardiology fellow at Texas Children's Hospital. And so if Ellis, you ever watch this, thank you very much. So I'm going to ask, let me ask David Barris what he thinks about this tracing, what he might do about it.
Okay, so we have a nice history that ingested an entire bottle of amitriptyline. So that's a TCA, tricyclic medication. So I'm just looking at the ECG. It looks to be that our QRS is wide, which I know that amitriptyline can cause PR prolongation, QRS, and also QT prolongation. The QT, just by eyeballing, it also looks very, very wide.
Yes, so that's excellent, David. You hit that question out of the ballpark. Very good. So just as you just said, tricyclic antidepressants can cause a widening of the QRS, and they can develop a right bundle branch morphology, which I guess we don't really have in this case. It's more of an interventricular delay. As you also said, lengthening of the QT interval, widening of the PR interval, and they can develop torsade. Remember again that the formal definition of torsade is polymorphic ventricular tachycardia in the setting of a long QT interval. So, and in fact, according to Ellis, this patient did develop a little bit of VT. And there are reports of people who even develop a Brugada pattern. And the reason for this, of course, is that the tricyclic antidepressants are sodium channel blocking agents, and in toxic levels can cause all of these ECG changes, which we would expect in anybody who is on a sodium channel blocking agent who has too much of that agent. And actually, one of the reasons that psychiatrists try to avoid these medications if they can is because one of the side effects of antidepressant agents, particularly tricyclics, is that particularly in young people, I believe there is some literature suggesting it can make people suicidal. I think that's generally true of a lot of antidepressant agents in depressed people, is that as they get better, they paradoxically become more suicidal, or at least more effective suicide candidates. And so, and since it has these potential toxicities, we would really want to avoid this type of agent in general, although without being a psychiatrist, it's my understanding that there are some patients for whom they are life-saving. They can also cause sinus tachycardia from the anticholinergic effects of these agents. And the treatment for this is sodium bicarbonate to alkalinize the patient and to give them sodium. And they apparently can also develop very profound hypotension. So inotropic support, vasoactive agents to treat hypotension, it will eventually resolve. You can also get ventricular dysfunction in a patient who has toxicity of tricyclics, again, it will typically resolve if you can control them and maintain them in hemodynamic state, in a hemodynamic state during the toxicity. So this is a very important tracing that you should try to keep in the back of your mind. There's a reasonable likelihood that at some point you may encounter this in clinical practice. Okay, let's move on here. Okay, this is a 2-month-old who is postoperative hour 2 following tetralogy repair. I think I'm going to ask Dr. Sergey Babia what he thinks this could be and how he would consider managing this.
Well, I think it's probably jet.
Mm-hmm.
And the way we usually deal with this
Well, please
is
expound on the diagnosis
why.
first, how you came to this decision, which I am not disagreeing with, but I'd like to share with the audience how you came to this idea.
So there is it's a narrow complex tachycardia.
Is
The
it?
heart rate, narrow complex tachycardia.
Is it narrow?
Well,
In a 2-month-old, is this a narrow QRS?
it's only 2 small boxes.
This is not a narrow QRS in a tech.
It's a white QRS.
But why might a, so the question is not so much, is it a narrow QRS, is it the patient's usual QRS?
Right, correct. That is true. And in order to understand that, we need to compare it to the previous EKGs. Do we have that?
Would you
option?
expect that this tracing would look like a patient who had tetralogy in terms of the QRS morphology? Was this?
Could be.
Yeah, right. I mean, normally, not uncommonly, especially if a patient requires some kind of RV outflow
RVH, yeah.
infection of some sort, right? They could have there's certainly a right bundle format to this QRS, right? Large R wave in V1 and V2, RSR prime. So yeah, this is a right bundle morphology, but I just think it's important to remember this is not a narrow QRS. I bring this point up because we've talked in the past about babies who have VT, and oftentimes their QRS is only mildly wider than the usual, and so this is definitively wide for a 2-month-old. But anyway, I understand what you meant, though, that this was probably the patient's usual QRS. But you're absolutely right, Sergey. What you would want is a 12-lead EKG after the patient came back from the operating room. And the only way to really know from looking at the EKG if this is the patient's usual QRS is to compare it to their QRS when they came back in sinus. And that's one of the reasons why after the patient has been tucked in and the sign out has occurred in the ICU and everybody feels that the patient is at least semi-stable, one should try to get a 12-lead EKG fairly soon after arrival. And the reason I say that is because it's unusual that an anesthesiologist will send a patient out of the operating room in a rhythm other than sinus. But it is also, when is the most common time that jet will appear, Sergey, after any kind of repair?
In the early postoperative period.
Well, be a little more specific than that.
First 24 hours.
Right. Well, usually in the first 6 or 8 hours, but not usually immediately upon arrival is the point I'm trying to make. It's not uncommon that the junctional excitability or enhanced automaticity will become more prominent over time, usually in the first couple of hours after you come back. So what I would say is it's worthwhile getting that EKG early on the course after surgery because you want to have a comparison, exactly what you asked me for a moment ago. Do I have a comparison? The answer is unfortunately no, I do not. But that is often the case. But it should not be the case. We should always try to get one. Obviously, you don't want to be pushing the nurses out of the way when they're, getting the lines set up and all of that stuff. But once everybody seems marginally comfortable with the patient on their bed and everything, and there isn't that, group of 400 people standing at the bedside, the first thing I would do is get a 12-lead EKG. Or at the very least, a limb lead EKG. Oftentimes when the chest is open, we perseverate over the fact that we can't get precordial leads. Ultimately, if you can get the arms and legs on there, you'll at least get a 6-lead EKG, which could be very, very helpful going forward. So assume for the sake of this discussion that the QRS morphology in sinus on post-op hour 0 was exactly the same as this.
Yeah.
So
that would make me think of jet. And so also on the EKG, if you look at it, you see that there is a VA dissociation. So we see more V's than A's. That's also a sign of jet.
Can you give us an example, a lead that you see it more clearly in, so to share with your colleagues?
Sure. So sorry about that. So for example, when you look at lead 2,
yep.
So you see QRS, T wave, QRS, and then I think there's a tiny P wave, T wave, QRS, then maybe another P wave, then QRS.
Right, that's exactly right. So the point is, if you look in the T waves from beat to beat, you notice that they don't look the same.
Right.
And as you astutely pointed out, there appears to be a P wave that might be superimposed here on the T wave or the QT interval. Here's a P wave that's a little before the QRS. So yes, there seems to be ventriculoatrial dissociation. Now, in people with jet, do you have to have ventriculoatrial dissociation? Is that a universal finding in people with jet?
I believe so, yes.
No, that's actually not true. You can have VA association, right? You can have accelerated ventricular rhythm with one-to-one ventriculoatrial conduction. That's certainly possible. But I guess it would be fair to say that if you read in a textbook about jet, they often will comment on the fact that there is ventriculoatrial dissociation, but actually you can have ventriculoatrial association as well, although it's not sinus rhythm. But you're absolutely right that in this example, this patient does not have ventriculoatrial association. It is dissociated. And again, as you also astutely pointed out, when there are more V's than A's, there are only 2 possible diagnoses, VT or jet. That's it, when they're in the setting of tachycardia. And so I agree with you that this is likely to be jet. So my next question to you is, what do you want to do about this?
So because it's...
Let me, before I ask you that question, I apologize for interrupting. It seems that's all I'm doing this morning. Let's assume for the sake of discussion that the patient is on a Peter Pastushko 0.05 of epi, 0.6 of milrinone, and is on a low dose of Precedex and is getting 1 mic per kilo per minute or per hour of fentanyl.
Mm-hmm. So Precedex is good. We're going to keep that. Epi, we would like to win.
Comment on why you said that about the Precedex for those in the audience who are unfamiliar with what you're trying to say.
I just remember you mentioning that there was research done that showed that after the era of Precedex started, there's less jet seen in the post-op period.
Well, it's partially true. What I said was that there are some studies that show that Precedex can actually be used to treat jet. It seems to reduce automaticity in the heart. It also causes sinus node dysfunction as well. In my personal experience, I've seen patients in which it worked fairly well, but then on post-op day 3, when we weaned it, they started to have jet again. So I think it's a reasonable approach, but it isn't. I don't think anybody would view this as primary therapy for jet. And in fact, in this example, the patient is already on Precedex and is in jet. By the way, since we're asking this question, what is the definition of jet?
It's junctional ectopic tachycardia, which means that the for some reason the sinus node is overtaken by the junctional pacemaker, I would say.
Right. So the other term for jet is His bundle tachycardia because it's believed to be from enhanced His bundle activity. Remember again what I taught you guys in the very first lecture on arrhythmias, that the rule of tachycardia in the heart is that whatever is fastest always wins. And so when you're in jet, the His bundle is firing at a rate faster than the sinus rate. It doesn't necessarily mean that the sinus rate is too slow. It's more that the His bundle rate is too fast. Okay, so now you've made this diagnosis. Is there any other? So you don't have an EKG to compare it to, and you're thinking in your mind it's like 9 o'clock at night. You're thinking to yourself, well, Dr. Pass said that this would be a wide QRS. It could be VT. How would you be able to prove that this is jet and not VT if you do not have a 12-lead EKG in sinus rhythm following surgery that preceded this tracing? Is there any?
Atrial electrogram.
Okay, so you do an atrial electrogram and it just shows exactly what you told me you saw in lead 2, which is that there's ventriculoatrial dissociation. So that still leaves you with the differential diagnosis of VT or jet, right? Mm-hmm. So how would you distinguish whether this is VT or jet?
Can I do that with that's a good, I don't know.
So the one quick way would be to pace the atrium. What would happen if you pace the atrium at a rate slightly faster than this rate?
You would take over.
And what would happen to the QRS if this were jet?
It will, if it's jet, it's gonna stay the same. If it's VT, it's gonna change.
That's right. So if you pace this patient at a rate faster than the jet rate, and there's AV conduction, then you should see the exact same QRS morphology, which would be a hint that this is jet and not VT. If the QRS morphology were to change when you pace, then that would suggest that this is VT. And the other thing I would say in regards to your definition of jet is it's any junctional rhythm that's associated with hemodynamic embarrassment in the post-op period, any junctional tachycardia. Okay, so you've paced the patient temporarily, you've proven that the QRS morphology is exactly the same, and now you are on call and Dr. Rajan is saying to you, okay, cardiologist, how should I treat this?
I'll start with cooling and getting off the epinephrine in this particular case.
Okay, so you're going to try to come off your inotropes because you're concerned that that's stoking the fire of this arrhythmia, and you're going to cool the patient. How cold do you want to make this patient, Sergey?
35 degrees.
Yeah, 35 would be a good goal temperature. And how are you going to do that, and how are you going to monitor that?
So I'll use cooling blankets, and I'm going to use the temperature probe.
Right. So you're going to use you need some kind of continuous temperature probe, because when you cool infants particularly, you can overshoot very rapidly. And hypothermia below the level you described, around 34, 35 degrees, can result in enzymatic problems with acidosis. You can even get VT from that. So you have to be very careful when you're cooling someone to continuously monitor the temperature so that you know at every second what the temperature is. Is there any other concerns when you cool the person? I'm going to ask Nivi, any other concerns you have when you're cooling somebody?
I mean, I'm not sure exactly, but I know we're trying to keep normothermia. If we let them get a little bit too cold, we're going to, we'll end up vasoconstricting, we'll have decreased perfusion to not end organs, but.
That's definitely true. But the point I'm trying to make is that when you cool somebody, you usually shiver. And that's right. And that's a bad use of cardiac output. And so you would want to either heavily sedate the patient or paralyze the patient.
Hmm.
The goal is to improve cardiac output, not lower it. So, so if you stay at the 34, 35 range, it's unlikely you're going to cause metabolic derangements, but it's definitely a concern. Okay, so now, Sergey, you have cooled the patient. And the rate hasn't changed very much. What would you do at this point? And the blood
Well,
pressure is a bit saggy. You know, you're like sort of 60, you're like 52 on 30, and you're nervous that something bad's going to happen, and someone's going to say, "How come you didn't respond to this before?" Because now all the monitors record everything. So, what's your next step?
well, my next step was to actually intubate, sedate the patient that you already mentioned. But I also have some medications on mind,
Okay,
so I could use procainamide
right. You could use
for
procaine.
that.
Right. What is your so you would give typically 5 per kilo, and usually do it 2 or 3 times. What's the big concern with procainamide?
It's vasodilation and decreased blood pressure.
That's right. So you have to have volume available, although usually when you give it in 5 per kilo boluses over 20 or 30 minutes, you do not see that, but it is possible. Is there anything else, any other non-pharmacological maneuver you could do?
Yeah. Mm,
To try and
there,
improve blood pressure, for example, and cardiac output?
Mm.
You can pace the patient, right? You can always atrially pace the patient, and that will give you AV synchrony.
right.
Now, sometimes that will improve the cardiac output. Sometimes it will not. Particularly, it almost always improves cardiac output when your heart rate is in, say, the 150 range, but it virtually never helps when you're this fast or faster. But it's probably always worth a try. And quite frankly, the way you do it is by experimenting. You're at the bedside and you pace at a faster rate. You just look at what happens to your CVP and to your blood pressure in order to determine whether it made sense to do that or not. So you're pacing. Your blood pressure is now 58 on 30, but you have to pace at like 190, and you're not excited about this. So procainamide would be one option. And just to complete the loop, the other option, if you wanted to, would be to try intravenous amiodarone. And typically the dose of amio is 5 per kilo. And we would typically give it slowly over about an hour. Some people will give it in smaller aliquots, like give 1 or 2 per kilo a couple of times, because I've heard others say that giving it as smaller doses sometimes is effective. Often 1 or 2 per kilo in some people's experience is all you need, and then you would start a continuous drip. What's the natural history of this? So now you've got control of the rhythm. You're on your procainamide. You're pacing at 150. You have AV synchrony. Your blood pressure is 69 on 35. You're making urine. Everything is fine. But the mother, who's sitting at the bedside, is quite nervous because she saw how much you had to struggle to get the rhythm back. So what are you going to say?
I'm gonna actually calm her down, saying that this is an arrhythmia that's usually observed in the early postoperative period, and it goes away, so it shouldn't be an issue.
That's right. It self-resolves. In the majority of patients, within about 48 to 72 hours, it will resolve on its own. But let's be careful and remember that this is a life-threatening arrhythmia. And before we knew about cooling and proc or amiodarone and pacing, people died from this very routinely. This was a very common reason that people would die after open heart surgery, because people did not know how to manage it. And early in my career, when I would sometimes do medical legal consulting, I might also add, always in the favor of doctors, always defending physicians, I saw more than one case of ICUs that improperly managed this. So you want to be careful in this. The other thing I will mention in regards to the amiodarone is you do not need to cool a patient to give amio. And that is often viewed by those who are in favor of amiodarone as one of its chief benefits versus the cooling and procainamide approach. Because if you don't have to cool the patient, it means that you could extubate the patient at some point earlier, right? Once you cool a patient and give procainamide, you pretty much have committed to an additional 24 hours of intubation and mechanical ventilation. And that, of course, carries its own risks. So some would say that that risk is so high that you should avoid that if you can. That said, I think the evidence is reasonably strong that the approach of cooling with procainamide is probably the most effective approach. But amio is a very reasonable approach as well. Lots of people prefer it. In fact, I think it'd be fair to say that most intensivists prefer it. But the evidence that it is effective is actually less compelling than that of cooling and proc if you really seriously look at this literature. Okay, very good job, Sirke. You have treated the patient, and she did well. Okay. So, why don't we ask Dr. Uzoma Obiaka. So, Uzo, you are out in practice wherever you are, and you were kind enough to send me an ablation to do. You're very excited that you had a case, and you were very nice to send it to me. And I send you a letter and say everything went great, and then you're seeing them in the office, and this is the EKG you see. So, what do you think?
Okay, so good morning, Dr. Pass. Looking at the rhythm strip, and there seems to be like a 1-to-1. So for every P wave, I think I see a QRS. But that P wave looks very prolonged, so I really don't think that that's being conducted. Sorry, just a minute. So yeah, there seems to be a 1-to-1 relationship, PQRS, with a prolonged PR interval, very prolonged PR interval.
Mm-hmm. Mm-hmm.
But the PR interval dose seems to change, because if I look in the first half of the strip, the PR looks really long, and that's why I'm questioning if it's being conducted. But if you look towards the end of the strip, the PR interval normalizes and seems to be conducted.
Right. So, so what do you think about this?
So there's definitely some form of heart block going on.
Right. You're probably at this point thinking that maybe you should not have referred this patient to
no,
me.
definitely. I'm thinking I should have referred this patient to you to help me figure out what is going on.
Well, except I've created a problem for you, haven't I?
No, not at all, Dr. Paz. So I'm kind of torn between saying a first degree heart block, but then I don't think this is conducting in the first thing. So I would sort of say maybe like a complete heart block just because I have regular RR intervals.
Okay, so that's an interesting observation you're making. So I agree. This is challenging, right? Because on the left-hand side of the screen, as you astutely pointed out, the PR interval is very long. On the right-hand side of the screen, the PR interval is long, but much shorter than it is on the left-hand side. So you're right, Uzo, in saying that. So first of all, I think the patient is in sinus rhythm, right? The P wave is upright in 1 and F. But you're right to be questioning regarding whether or not this patient is conducting or not, because the PR interval is changing over the course of this tracing. So what you would need to do is see a longer rhythm strip on this patient in order to know if this is what sometimes we call isosynchronous depolarization, where the ventricular and the atrial rate are almost at the same rate, and so it appears as if there's conduction when there isn't, or if there's changing in the PR interval. And the individual who sent me this tracing told me that this was in fact due to a injury from an ablation, and during an AVNRT ablation, the patient received steroids and this resolved. So this was an example of getting a little too close to the good stuff, as it were, and we'll go over AVNRT in a short while. So Yeah, so this would be a worrisome finding if you saw this in clinic in somebody who you had referred for an ablation.
Sorry, Doctor. So, Dr. Pass, I'm not sure. So, what did the person say? So, what was the conclusion? Was this like
Well,
a
the conclusion
testing
was,
people?
when this was observed at a longer rhythm strip, what we saw was that the PR interval, what I'm told is the PR interval was varying from, when the heart rate got a little faster, the PR interval was a little longer. When the patient was a little bit more awake, the patient had a shorter PR interval, but it definitely appeared that the PR was varying, but there was definitively a one-to-one
One.
relationship between the P wave and the QRS. And so this suggested that there had been some injury. Would this be injury to the fast pathway, Uzo, or to the slow pathway if someone had AVNRT?
To the fast pathway.
Right, it's to the fast pathway because when we do AVNRT ablations, right, we're modifying the slow pathway, which we believe is not necessary for normal AV nodal conduction. So this is this would be an example of a slightly over-exuberant attempt at AVNRT ablation. And this is what always worries us when we're doing AVNRT ablations, and why it is that we always try at first to ablate as far from the compact node as is possible in the area of the slow pathway. But sometimes even when you're in the right place, this can occur. So I certainly do not think that this is a sign of a bad ablator. This can happen, unfortunately. Okay, and along those same lines, I'm going to ask, let's see here. Dr. Perna Bonsall, I see you there. I'm very excited that you're there, Dr. Bonsall, because I remember the last time I spoke to you, you told me that you would be doing some skydiving. So I'm assuming the fact that you're here means you survived that activity. And I might also add that one needs special permission to do that from their mother. What's happening here, Perna? And welcome back.
Good morning, Dr. Pass. Thank you. I knew the moment I'd speak to you, this would be the conversation.
Well, I was worried for 2 weeks. I was sitting here nervously. You have to ask Grace Kong. I mentioned it many times. Okay, so what's going on here? We're in an EP study and we're performing rapid atrial pacing, as the sign says.
Mm-hmm. And if I look here, so 356 milliseconds is like the sorry. So basically we are measuring the time interval between two beats. That's 356 milliseconds.
Mm-hmm.
And then with rapid atrial pacing, it has decreased.
So I'm rapid atrial pacing, right? And all these calipers are showing is that when you go from the left-hand side of the screen to the right-hand side of the screen, the interval from paced beat to paced beat is shorter, meaning that the heart rate is faster. So,
right.
So we are, this is an example of Josie pacing the atrium faster and faster. And what do you observe is happening in the HIS bundle, in the HIS recordings?
So basically I'm trying to look at the AH interval. And then here when the cycle has become smaller, shorter, I'm just trying to see if I can calculate.
Well, it's hard to calculate anything.
Yeah.
To your eye, do you notice a difference? Remember also, it's always important when you're looking at intracardiac tracings to look at the surface electrocardiogram, because oftentimes the answer can be there as well.
So I do see that the AH interval has prolonged as the cycle has gotten shorter. And then we normally try to see how much is the change, because if there is a jump of more than 50, it is suggestive of dual AV node physiology, suggestive of an AVNRT.
So that's exactly true when you're doing atrial extrastimulus testing, but you are right that when you rapid atrial pace, if you see a very large jump out in the AH interval, that would be suggestive of dual AV node physiology. I'm going to go to the next slide and show you what happened when Josie was pacing just a little bit faster. Now we're pacing at a rate of 183 beats per minute. So I'll just show you. So here you're at 177, and as you astutely pointed out, the AH interval here from A to H is markedly longer than it was here at a slower pacing rate. Now she's gotten just ever so slightly longer. And what are we seeing here?
It has markedly increased the AH interval.
Right. And in fact, what we're seeing is that the A, or the P wave, is actually starting either simultaneous or maybe even before the onset of the prior QRS. Okay, you can actually see it a little better on this beat. But there is still, so a very long AH interval. And when you see that the pacing spike is actually, or the P wave precedes the previous QRS, and the so-called PR interval is longer than the R to R interval, that is a sign of what we refer to as sustained slow pathway conduction. And sustained slow pathway conduction is the other way that we make the diagnosis of dual AV node physiology. So you appropriately said a moment ago that when we do atrial extrastimulus testing, if we have a greater than 50 millisecond increase in the AH interval for a 10 millisecond decrement in the atrial extrastimulus, we consider that to be evidence for dual AV node physiology. Another demonstration of dual AV node physiology is what this tracing is about to do, which is to show you sustained slow pathway conduction. Now, I didn't show you the rest of the strip, but you notice in this beat here that the pacing spike is clearly before the onset of the QRS. And this paced atrial complex did conduct to the V. So this is an example of sustained slow pathway conduction, which is consistent with a diagnosis of probably having AVNRT in a patient, of course, who has SVT. So I'm glad to see that despite the mortal danger you put yourself in, still are remembering your electrophysiology. I'm also glad you're still alive. I'm sure your mother is. So this is actually a nice little description from Instagram. Some adult EP guy, I think he's a fellow, actually put these couple of slides up, so I thought I'd show them to you because I thought they were very nice. So what happens when we have, so this is an example of the fast pathway and the slow pathway. And so remember that in order to have reentry, you need to have three conditions. You have to have two pathways that are conducted proximally and distal. You have to have a unidirectional block in one pathway, because remember, if you have a P wave up here and it's coming down and it can go down both pathways at the same time, there's no possible way for reentry because both pathways will have depolarized. So another way of saying that there is unidirectional block is saying that there is a difference in the refractory periods. So if you put a P wave in at a coupling interval that is short enough to block in one pathway, typically the slow pathway, but not the fast pathway, what can happen is it can go down the, or the other way around, I should say, it can go down the slow pathway, but not the fast pathway. So what happens is that the P wave temporarily blocks in the fast pathway, it goes down the slow pathway, and remember that the third key feature of reentry is that there needs to be an area of slow conduction or a slow zone. Why is that? Because if it conducted rapidly through, if both pathways conducted rapidly, when the P wave goes down, by the time it comes back around, the fast pathway would still be refractory. Let me go backwards, sorry. It would still be refractory. So again, you need to have two pathways. There needs to be a difference in the refractory period of the two that will allow for unidirectional block in one of them. And there needs to be a zone of slow conduction that is just slow enough that by the time the impulse comes down, it can re-enter again. And that's what this diagram here is showing, is that the impulse goes down the slow. Because it's a slow conducting pathway, it takes a while, and by the time it finally reaches the bottom of the reentry loop and is about to activate the fast pathway, it is no longer refractory and it allows reentry to occur. And so the atrium above this reentry circuit in the AV node and the ventricle below the reentry circuit are being passively depolarized as the reentry occurs. And this is a very nice little diagram demonstrating the triangle of Koch, which we remember is bordered by the tendon of Tartaro, the anterior leaflet of the tricuspid valve, and the mouth of the coronary sinus. And so this is this little area that we're trying to work in. And so this is a very stylized and simplistic version, but it isn't too far off from truth. And so we believe the fast pathway is kind of up here near the top, and the slow pathway is sort of down here in this area. And so, as you've probably noticed in the cath lab, what we're always trying to do is to singe the slow pathway fibers down here and stay away from the compact AV node, which we know is located in the most superior portion of the triangle of Koch. And so in some cases, we are able, by burning down here in an area that ought to be safe in most patients, we're able to terminate tachycardia because we've broken part of the loop. But in some patients, we need to really edge our way up quite a bit higher. Presumably in the case that Uzo was analyzing, the catheter got a little close to this area. And the reason that sometimes people get, and so what you'll notice when we do these AVNRT ablations is that we will typically put a few applications down here and then try to reinduce. And if we can't reinduce, we consider ourselves lucky because we were able to ablate it at a very low position. But it isn't uncommon that we have to keep working our way up until we finally are not inducible. And every once in a while, we have to get ourselves fairly close to the good stuff, as it were, to the fast pathway, which is what we do not want to ablate. I think historically, it's interesting to note that when ablation for AVNRT first began, the actual technique was to go after the fast pathway. And I think in Germany, they were doing the first AVNRT ablations. But as you might imagine, there was probably a 25 or 30% incidence of heart block with that approach. And so that rapidly fell out of favor, obviously. Let's see if I had one more picture. So here is an example of a Carto diagram, also from the same nice little description. And so the yellow dots are the where the His was recorded, so presumably very close to the AV nodal fast pathway. And as he wrote here, you don't want to burn here. And this is the area where we would put the slow pathway applications in, and each dot is a burn. So, you know, you could easily, in your mind's eye, superimpose this image onto this image, and you could imagine that these dots here are basically applications being placed down here in the patient with AVNRT. So I thought this was a very nice nice demonstration that somebody was nice enough to put online. And then what they show you here also in this is that when you put in an extra stimulus, what happens is it blocks in the fast pathway, it jumps to the slow pathway, which is why the AH interval is so long, and then it comes back up the fast pathway rapidly and then again down. And so again, we're going down the slow with a very long AV time, and then the VA interval is very tight because we're going up the fast. So in typical AVNRT, we're going down the slow pathway, but up the fast pathway. In atypical, it's reversed typically, usually, in which case we're going down the fast and we'll go slowly up the slow pathway. But this is the more common finding, which is down the slow and up the fast when someone's having AVNRT. So you can even learn something on Instagram. Okay, this will be our last tracing of the day, and I think we will ask Dr. Kong, who I believe is in the audience today. I'm sure she's very
Dr. Pass.
Oh, you, Grace. I'm sure you're very happy to know that your colleague made it through her skydiving activities, or else there would have been a lot more call for you.
Yes.
I'm sure
Very
that's the reason you're happy about that. So here's a 12-year-old brought to the intensive care unit after a search for him and his family following a skiing accident. What do you think? Is there anything unusual about this?
The cuirass appears wide.
Mm-hmm.
There's an arrow.
There's an arrow that is being covered. Anything else you observe that's unusual in this tracing?
Patient's very bradycardic,
Correct.
and the QT appears prolonged.
Right. So what that arrow is actually blocking is what's referred to as a J wave. And this is an example of a patient who has a hypothermia injury. And so when patients are hypothermic, they develop sinus bradycardia. They get prolongation in the QT interval, and they can develop these little J waves. And apparently they're best seen in the inferior lead, so 2, 3, and F. And we see it here. And the height of the J wave apparently is proportional to the degree of hypothermia. So as you rewarm a patient who has hypothermia, the J waves should respond and resolve. And according to what I read, it's due to differences in the shape of the action potential between the epicardium and the endocardium. And as I said, with rewarming, this will resolve. So if you do see a patient who is very hypothermic, then, because I know you've been considering moving out to Montana following fellowship, this could be a problem for you, Grace, but you want to keep that in mind in regards to waves and a very long QT interval and bradycardia. And I think with that, we'll leave it. We're 45 minutes in. Any questions before we stop the call here? Okay. All right, guys, it's nice to see you all. Hope everybody has a great day, and I will see you in a few minutes at sign out. Take care, everyone. Bye.
Thank you, Dr. Pest.